As you know, doctors, wellness in every home and happiness in every heart has with your with our beloved doctor March every year. World Kidney Day Joint Steering Committee has declared 2023 to be the year of kidney health for all, preparing for the unexpected and supporting the vulnerable. The 2023 campaign will focus on efforts to increase education and awareness about kidney health. This time, we have brought to you an online talk on recurrent renal calculi and its impact on kidney health. Today, we have with us eminent clinician as our speaker to discuss and interact with you on this topic. Please join me in introducing and welcoming him. It is my honor and privilege to introduce Dr. Sushil Kharbanda, sir. A very warm welcome to you, sir.
Thank you. Thank you, Dr. Vijay. Thank you.
Dr. Kharbanda, sir is working as a chief urologist and robotic surgeon at Cystone Hospital, Urology and Laparoscopy Hospital, New Delhi. Dr. Kharbanda, sir, has done his MBBS and MS from SMS Medical College, Jaipur. And further to that, Dr. Kharbanda, sir, has done DNB in genitourinary surgery from PD Hinduja Hospital, Mumbai. Dr. Kharbanda, sir, has vast experience as consultant urologist and worked at various reputed hospitals like PD Hinduja Hospital, Mumbai, Dr. Ram Manohar Lohia Hospital, Delhi, Mulchand Hospital, Delhi. So, sir has got vast experience. Dr. Kharbanda, sir, has conducted more than 30,000 endourological surgeries till date. Dr. Kharbanda, sir, has been working as a teacher, has been imparting training to the various aspirants in various hospital. Yes.
Sir, your slides are not changing, it seems. Can you please put on our slideshow?
Sorry.
Thank you so much.
It's not changing?
No, they are not changing, and they are also they are not on a slideshow, sir. Can you please do it?
Sorry. Is this visible now?
Not right now, sir.
Sir, stop, share your screen and then share it again.
Okay, fine. Thank you. Is this visible now?
Yes.
Sir.
Is this visible? Okay, fine. Fine, thank you. Thank you, Mr. Akash. Sir has also been imparting knowledge and training and skills about RIRS. Also, sir has been working on various research projects like treatment and prevention of renal calculi, male infertility, erectile dysfunction, and prostatic disease, etc. Sir has attended various conferences, workshops, and attended and presented papers in various national and international conferences. Also, sir has been a member of various professional forums. And so thank you for the joining, sir.
Thank you.
I also extend warm welcome and sincere regards to all the doctors who have joined for this session. We are happy to have you in this online talk. Please stay with us. Dear doctors, if you have any questions during the talk, please drop your questions, feedback on the chat box. We'll take up all those questions during the question and answer session. With this, I would like to hand over the session to Dr. Kharbanda, sir. Over to you, sir.
So I will share my.
Yes, sir. I'll just stop sharing.
Good evening, everybody. Myself, Dr. Sushil Kharbanda. I am working at Cystone Hospital as a chief urologist and robotic surgeon. First of all, I will like to thanks to Himalayan to giving me this opportunity to talk about recurrent urinary calculi and its impact on kidney health. On this specifically on kidney day. Actually, it was on 9th day, but we are all celebrating a whole month this March as a kidney month also. So my talk will be regarding the kidney and ureteric or bladeric stone that would be combined way, but we termed it as a urolithiasis. So urolithiasis from this word has come. It is a Greek word, urine and stone. That means any stone which is made in our urinary tract, those are known as urolithiasis. And what about nephrolithiasis? Nephrolithiasis is the calculi which are specifically in kidney. Nephro means kidney and lithiasis means stone. So whensoever the stones are kidney, that we call it as a nephrolithiasis. Now, regarding the background of urolithiasis, urinary stone disease continues to occupy an important place in everyday's urological practice. And the average lifetime risk of stone formation has been reported in the range of 5 to 10%. That means around 5 to 10% of general population will going to form some sort of stones in their whole lifespan. And the most common age group is 20 to 49. And if you ask me, the peak incidence is in between 35 to 45 years. But you ask me, I have the minimum age which I have operated on a patient for stone disease. That was around 9 months, and maximum I had operated around 98 years. So at no age is left behind for renal or urolithiasis. You can have any age you can have urolithiasis, but most common incidence is at from 35 to 45 years. Recurrent stone formation is a common problem with all types of stones, and therefore an important part of the medical care of patients with the stone disease. If you ask me what is the rate of recurrence, the rate of recurrence depends upon from where it has been. From first year, it is around 10 to 15%. If you ask me in next 5 years, it will be around 50%. If you ask me in next 10 years, it is around 75%. So you have, once you had a stone, if you had got treated or it had been spontaneously, it has been out, then there are good chances in another 10 years or so, there is 75% chances you will be having a recurrence. So according to the site of stone, it can be in, as I told you, either they can be in kidney, they can be in our ureter, there can be in bladder, they can be in prostatic urethra, or they can be in our anterior urethra. Now, classification of kidney stones according to their chemical composition. They can be calcium stones, uric acid stones, white stones, and cystine stones. Calcium stones are the most common. Second one is uric acid, and third one is a white one. Now, coming on to the pathophysiology of stone formation. The formation of renal calculi is a complex process, depends on the interaction of several factors. Urinary concentration of stone forming ions like calcium or oxalate or phosphates, urinary pH, acidic or basic, urinary flow rate, is there any obstruction or not, if there are any obstruction at any level, or maybe at the PUJ level, maybe at the ureteric level, maybe at the prostatic level. So whenever there is any obstruction, there is a stasis of urine. The more the stasis of urine, there are more chances of forming of stones. And then the balance between promoter and inhibitors factors of crystallization like citrate and magnesium, these are the inhibitory, and oxalate and other factors are promoters. Now, another is anatomic factors that encourage urinary stasis. For example, development anomalies like PUJ obstruction or megaureter, posterior urethral wall, or any foreign bodies. Now, there are three theories for stone formation. One is nucleation theory, stone matrix theory, and inhibitor of crystallization theory. Now, mechanism of stone formation. Now, there are four steps are involved. First is crystallization, that is from at the micron levels. Then is the crystal growth is there, and then is aggregation of that crystals, and last there is the adherence of crystals to the epithelium. Must, because for the development of stone further, that any crystal, it should always anchor to some kidney tissue, so that any epithelium of the kidney tissue, so that it can grow inside. Otherwise, it's going to wash it with the urine. Now, general concept and steps in kidney stone formation. Now, there are different factors which are responsible for kidney stone formations. Some are like age, sex, nutrition, minerals, climate, which climate he is living, inheritance, water intake, and some are abnormal renal morphology, disturbed urine flow, as I told before, urinary tract infection, metabolic abnormality, Crohn's disease, RTA. This leads to uric acid stones and all. Then there is a nucleation, crystal growth, and crystal accumulation. And finally, there is a stone formation. Now, coming on to the calcium stone, which comprises 80% of all stones. The two most common type of calcium stones are there. One is calcium oxalate, and another one is calcium phosphate. Among these, calcium oxalate is more common. Again, calcium oxalate can be of two types: calcium monohydrate or calcium oxalate dihydrate. Now, there are certain medications which are associated with calcium stone formation, like acetozolamide, amphotericin, antacids, glucocorticoids, loop diuretics, theophylline, and others. Now, coming on with the calcium oxalate stone, as I told you, this is the most common type of stones. Can be a calcium oxalate monohydrate, can be calcium oxalate dihydrate. Dihydrate stones are actually more hard. Monohydrate are they are very soft kind of a thing. The most preventable cause is dehydration and low urine output, whereas other factors in person's diet can cause these stones, including high sodium intake, high oxalate intake, and high protein intake. So for calcium oxalate, you can see, if you ask me what are the factors, it's not about taking high calcium. Actually, which is more important is high oxalate, high sodium, and high protein intake. When you are having an appropriate amount of calcium, actually that inhibit your stone formation. Now, what are the risk factors in treatment? Now, as I told you, most common risk factor is low urinary volume. That means dehydration. That means he or she is not taking excess amount of the fluids with me, exercise, sweating, or low fluid intake, or bowel disease. And treatment should be high fluid intake. Another is hypercalciuria. That means he or she is losing a lot of calcium from urine. Hyperoxaluria, hypocytruria. In my own clinical practice, what I found, we had done so many studies for recurrent stone formation, and I had done thousands of persons to whom I had done stone analysis, and their 48 hours urinary investigation for recurrent stones. What I found, the most commonly in around 80% of the patient, what I found it was hypocytruria. And type of hypocytruria, I didn't found any disease among these, and it was idiopathic. So most common factor, according to me, in our Indian scenario is hypocytruria. So if you give that patient to a lot of citrate, then there will be less chances of formation of stone. Now, after calcium, coming on to the uric acid stones, these are the second most common type of kidney stones. These are often seen in patients with low urinary pH and low urinary volume. This type of stone is associated with individuals that have chronic diarrhea, volume depletion, high animal protein intake, and sometimes myeloproliferative disorders. And what are the etiology? Excessive dietary purine intake, hematological or myeloproliferative disorders, phosphodiesterase pyrophosphatase synthase inhibitor deficiency. Now, for uric acid stone, which has a high purine intake, for which foods which have high purine content are like alcohol. Alcohol mainly beer. Beer has a very high purine content. Asparagus, cauliflower, chiku, custard apple, and all these things have meat specifically, or red meat and all, mushrooms, shellfish, spinach, and these all have a high purine intake, high purine content. So they all promote uric acid stone formation. Now, there are certain medical conditions like RT and primary tubular defect, and some iatrogenic administration of various uricosuric drugs also promote uric acid stone formation. Persistently low urinary pH is one of the factors which promotes the uric acid stone formation. This is the uric acid stone risk factors and treatment. As I told you, low urinary volume, increase fluid intake, acidic urine, make it alkali, give again some alkalizer, hyperuricosuria, excess, that means there is excessive urine ingestion, dietary urine restriction, and allopurinol or fabulosis. Both of the drugs you can give. Now coming on to the third most common, that is the struvite stones. So many of these patients have urinated. Most of the struvite stones are the most quickest forming stones. For instance, they grow very fast. Many of these patients have urinary tract infection, and the most important factor for struvite stones is infection. So whensoever of male or female, these are basically more common in females. In males, struvite stones are mainly in the bladder, and in females, they are mainly in the kidneys. And what is the most important factor? That is a recurrent urinary tract infection. Urea causes, since UTI is the most common in female, it is more common seen in the stone in the female, as I told. Now, associated struvite stone formation associated with infection of urinary tract, especially those caused by urea-splitting organisms like Proteus, Mirabilis, Klebsiella, Staphylococcus, Xanthomonas, and other. And common in biologically female individuals, they tend to grow large, filling part of the renal pelvis and calyces and adopting a staghorn type. As I told you, the staghorn type, struvite stones are very fast growing, so they take the full shape of calyces, and specifically the staghorn shape. That's why most of the staghorn calculi are struvite stones. Coming to the cystine stone, these are the very rare type of stones. They are caused by some genetical conditions that increase cystine in urine. So, what are the main reasons for kidney stones? So, habit of drinking less water. This is most common. Proof of having hereditary stones. Yes, it is inheritable. Not always, but yes, it is inheritable. If your parents have, you have a good chance you will also have a stone formation, which is not always true, but it is there. Recurrent urinary tract infection, urethral obstruction, excess intake of vitamin C or calcium drugs, stay sick for a long time, that means you are more on bed most of the time, suffering from hyperparathyroidism, of course, when PTS is more, the calcium excretion from kidney is more, so there are more chances of calcium stone formation. Now, coming on to the symptoms of kidney stones. Pain and difficulty in urination is the most common symptom of any kidney stones. Kidney means uric acid now. Nausea and vomiting always associated, most of the time it is associated, the pain is associated with nausea and vomiting. Hematuria, that means you might pass blood in urine. Fever, most of the time, whenever these kidney stones are having associated with urinary tract infection, they give rise to fever. Most of the time, fever is with chills and rigors. And sudden and sharp pain at your fat, that means on your sides. Now, what are the risk factors for stone disease? As I told you, there are some known modifiable factors like family history, ethnicity, age, and gender, and some are lifestyle related like diet, dehydration, overweight, obesity, diabetes, and hypertension. And again, there are some environmental factors also: occupation, geography, climate, and temperature. Of course, if you are working in a very hot climate and most of the time you are in outside and you are not uh, keeping yourself fully hydrated, of course you are going to form stones. These are the factors I already discussed: obesity, family history, inadequate water intake, high animal protein intake, high urinary calcium levels. Now, coming on to the laboratory investigation, stone analysis, of course, that will be done after when he or she has expelled the stone or somebody has removed it. Blood analysis, calcium, albumin, creatinine, and urate has to be done. Urine analysis, starting from dipstick to cystine level, calcium level, phosphate level, citrate level, urate level, and coming on to the urine culture also. Now, coming on to the radiological imaging. So, see, there are whensoever patient has come to our OPD with the sharp flank pain or any symptoms which are suggestive of urolithiasis, first investigations which we do is after investigations and all, and that is ultrasonography. If ultrasonography is suggestive of any calculi or something, if we or any hydronephrosis or something, then we do either X-ray KUV. And nowadays, in imaging, plain CT scan is the gold standard for any urolithiasis case. It is going to catch even 1 to 1.5 mm of stones, usually which are not picked on ultrasonography or X-rays. So gold standard for urolithiasis should be plain CT scan. That will be NCCT KUB urographic values. Another investigation which are done are mainly IBP. Okay, and there are other investigations like uroflow if you are suspecting any obstructing in urine. And blood investigation routine, KFT, CBCN has to be done. Now, these are the X-rays. You can see on your extreme left, there is a stone, which is this. Actually, this is the ureteric catheter, and there is a stone in the mid-ureter. See how we classified it up, mid, and low. Yeah, from ischial tuberosity, from up to it is upper ureteric. From here to here, it is mid-ureter. From here to our UV junction, it is lower ureter. So these are the like staghorn stones and multiple secondary stones. So this is a summary of radiological imaging: KUV, ultrasound, IVP, CT scan. As I told you, CT scan is a new gold standard. No intravenous contrast is needed. This is one of the benefit of contrast in plain CT scan. It is very highly sensitive and specificity. Detects radiolucent stones also. This is one of the more advantage of going through NCCT, because in plain X-ray or IVP you are going to miss radiolucent stones which you are going to catch on plain CT scan. Detects other causes of flank or abdomen pain also. Now, coming on to the treatment. The treatment of kidney stones depends on the following factor: the type of stone you have, one, location of the stone, how bad it is, length of time you have had that symptoms. Many stones pass out of the body without treatment. Say, first I told you the type of stone you have. This you are going to know after you have expelled it. Another is the location of the stone, whether it is in the kidney, in the ureter. And when you talk about the ureter, it's not only ureter; it can be upper ureter, mid ureter, or lower ureter. Because the chances of spontaneous expulsion is very high when they are in the lower ureter. They are moderately low when they are in mid ureter, and they are very low when they are in the upper ureter. And how bad it is. And one thing they have missed is the size of the stone also, because size is the most important factor if you ask me. Our ureteric diameter is around 4 mm. So what we say, spontaneous expulsion of a stone, which is around 5 to 7 mm. There are good chances of spontaneous expulsion. If you ask me how much, then it is more than 50% chances of spontaneous expulsion. But as the size increases from 7 to 8 or 9, the chances decreases dramatically. Another is the type of the stone also, and the shape of the stone also matters. If it is a rounded stone, the chances of spontaneous expulsion are low. If it is an oval, and there are the spontaneous expulsion chances are high. And how bad it is means, see, when you ask any patient to wait, say it, you should ask any patient to wait only when if he or she is able to wait. We can't see if somebody is getting twice or thrice every time she's just getting injection for pain. She's not he or she is not better on with any oral painkillers. Every day he or she is getting. There's no point in waiting. No point. But the size of the stone. So if it is giving a lot of symptoms in the form of pain, or it is giving a urinary tract infection, it is giving a lot of fever and all. If it is completely obstructing your ureter, it is affecting the kidney, then you point in waiting. Yes, if there is a stone in your ureter and it is not giving you that much of pain, there is no that much of infection, you are comfortably taking it. Yes, up to 4 to 6 weeks you can wait, but not after that. So that is the thing. When you have waited up 4 to 6 months, then there are some permanent damages start in the kidney due to backflow of urine. Okay. Another is the length of time. As I said, length of time you have had symptoms. Now, wait for the stone to pass by itself. Waiting up to 6 weeks, as I said earlier, 6 weeks is safe. If the pain is bearable, there is no sign of infection, the kidney is not fully blocked, and the stone is small enough that it's likely to pass. So if a stone is around 14, 15 mm, you can't ask him to wait and all. And even 6 weeks is too much for him. So 15 mm or something you are handling, you are directly saying, okay, you have to get it removed. But yes, if it is 5 to 7 mm, then of course you can ask him to wait and watch, unless he is not having intractable pain or infection. Now, most common medicine prescribed is tamsulosin. Yes. Now, another is tamsulosin. Nowadays, we are using another alpha blockers like chelodocin also. Coming on to the surgery. Surgery may be needed to remove a stone from the ureter of the kidney. If the stone fails to pass, one, most importantly, the pain is too great to wait for the stone to pass. The stone is affecting kidney work. So these are the other medications. Usually, most commonly, what we are using is thiazide diuretics and potassium citrate. Now, coming on to the stone removal, the site, and shape, as I told, of the stone at the initial presentation influence the decision to remove the stone. Size, site, and shape. Shape is also important. Also, the likelihood of spontaneous passage must be evaluated according to, again, site, stage, and shape, and to the clinical scenario of that patient also. Spontaneous stone passage can be expected into 80% of the patient with stone smaller than 4 mm. As I said, for stone with a diameter exceeding 7 mm, in the chance of spontaneous passage is very good. As I told you, proximal ureter, it's 25%, mid ureter 45%, distal ureter 70%. Now, it's usually indicated, stone removal is indicated for stones with diameter exceeding 6 to 7 mm. There are different techniques we are using for this. Indication of surgical operation, we are discussed. The frequent attack of renal colic, disorder of the urine outflow causing the hydronephrotic degeneration of the kidney. There is obstructive area. This is the point where you should do it at the moment only. Frequent attacks of acute pyelonephritis, that means he's getting a lot of urinary tract infections. Total hematuria, intractable hematuria, what we call as calculus pyelonephrosis, stone at the sole kidney that causes obstruction. That means having the single kidney and which is obstructed. stone in the ureter of the solitary kidney that won't pass by spontaneously. These are the indication of surgical operation. Now, the different people think differently about doing a bacteriuria before carrying any stone. But in my center, I always do urine culture before doing any stone disease. Specifically for when you are going to do treat some staghorn stone, most of the time staghorn stones are struvite stones, and for struvite stones, always give prior to my surgery. I always give maybe couple of 2 to 5 days of antibiotic before surgery. And for any other surgery, if culture is positive, I treat that patient according to culture for 2 to 3 days. Then only I operate on those patients. Now, what are the modern management of urolithiasis from ESWL, that is extra shock wave lithotripsy, ureteroscopy, percutaneous nephrolithotomy, that is PCNN, and laparoscopic approach to the stones. Now, open ureterolithotomy, pilototomy, or nephrolithotomy is required in less than 1 to 2% of modern stone management. From the last, I tell you very clearly, for the last, maybe I done my last open pilototomy that was way around maybe around 14 years back. So nowadays, most of the cases are easily handled by endoscopic surgeries. Now, this is chart is very important. There are the different treatment options for different clinical scenarios. Now, there are two things. One is stone site, and another is whether it is a symptomatic or non-symptomatic. Now, I'm going to just discuss the primary treatment options, okay? So, any symptomatic stone which is less than 2 centimeters, so we have primarily ESWL or ureteroscopy. Ureteroscopy means flexible ureteroscopy. Now, when there are asymptomatic stones which are less than 0.5 centimeter, of course, observation, as you know, okay, the spontaneous expulsions are more than 70-80% by do any surgery. Now, asymptomatic renal stone from 0.5 to 1 centimeter. Observation, of course, up to 1 centimeter we can observe. Another ESWL or flexible ureteroscopy. Now, when they are asymptomatic, more than 1 centimeter, but less than 2 centimeter. It was from 0.5 to 2, 1 to 2. So when they increase it from 1 centimeter, you should not observe because, of course, they are not going to expulse by spontaneously. You have to treat. So, but it's better to treat it when they are small in size, okay? Because then you don't have to do PCNL, which is more invasive form of treatment. So better to do with either lithotripsy or flexible ureteroscopy. But when they goes to from more than 2 centimeter, whether they are symptomatic or asymptomatic, PCNL is the treatment of choice. Now, ureteric stone without sign of infection, observation, 4 to 6 weeks as I told you. Ureteric stone that fails trial of passage, ureteroscopy. Ureteral stone with sign of infection and sepsis. In these cases, when there is a ureteric stone which has a sign of infection, that means increased counts or fever, and in those cases, first of all, we have started with ureteric stent placement, either this or putting a PCN, and then we have to, when the patient is stable, then either with the ureteroscopy or PCN. For staghorn, there is no other doubt. PCNL is the only choice. When the renal stones are with the PUG obstruction, we are along with the removal of stones at the time of pyeloplasty. Coming on to the ESWL, that means extra shock wave lithotripsy. Actually, what happened in this, if there are some waves which are from outside, which is directly targeted at the kidney stone, which to make it fragment. Now, there are that what means extracorporeal means from outside the body, shock waves means pressure wave, lithotripsy means package of the stone. Is a non-surgical technique for treating stones in the kidney or ureter. Ureter means only upper ureter. We can't treat any ureteric stone which with lithotripsy which are in mid or lower ureter, as there is a bone cage there outside. Stones are broken in the stone dust are fragments that are small enough to pass in urine. If large pieces remain, another treatment can be performed, like URS or flexible ureteroscopy. It's basically used most commonly and managed to cure 50% of the kidney stone patients. Actually, what happened? The stone treatment most of the time depends upon a lot of other factors also. See, as nowadays people are so much busy in their work, they can't take off for more than 1 or 2 days or so. But if somebody is opting for lithotripsy, which was very common previously, nowadays why it is not common? Because most of the time you have to go for multiple settings. If stone is around 1.5 to 2 centimeters, then you might have to go for maybe 2 to 3 sittings. Then again, you might, whensoever you are passing urine, you will feel pain, you will feel little bit passing of urine, little bit passing of blood, burning, pain, fever. These symptoms are also associated whensoever you are passing small fragments. So nowadays, people are not using lithotripsy as they were using previously now, because we have a better techniques like flexible ureteroscopy, that is retrograde intrarenal surgery, that is RIRS. Because what is the advantage of RIRS of lithotripsy is we are going to there again, so there won't be any incision mark or anything. So we are going to put a scope from urethra to ureter to the kidney. We are going to break the stones to small fragments with laser and take out the all fragments at the same time. What is the difference between lithotripsy and this is? In lithotripsy, with extra corporal shockwave, we are going to break the stones. And see, the fragments which are going to be broken, that are not in our hands, that is not controlled. So some fragments can be large, some can be small. So some fragments will be passed, and there every time what I had seen, the complete clearance with lithotripsy ESWL is very rare. So 70% chances that around 1.5 centimeter of stone, if we have done with lithotripsy, there will be a complete clearance. But with RARS, again, that is around 95%. So, and that will be in a single sitting also. So sitting also matters. So people are so much busy, they don't want to come again and again. So they opt for RARS over ESWL. Now there are 4 main elements in ESWL. One is energy source. Mostly nowadays, magnetic is used, focusing device, coupling device, localizing device. Localizing for most of the time, either we use fluoroscopy or ultrasonography. Now there are some absolute contraindication, that is pregnancy. So we can't use fluoro in pregnancy. That's why it is contraindicated. Again, that extra shock wave also, they travel through your gut and all. This is also absolute contraindication for ESWL. Another relative contraindication for lithotripsy are renal colic, urinary obstruction, infection, declining renal function, and significant hematuria. Now coming on to the ureteroscopy. Ureteroscopy means we are going to pass a small scope from urethra to the bladder and to passing into the ureter. So wheresoever is the stone. The most common treatment of lower ureteric stones. Now, even now for the upper, mid, and into the renal also, this is one of the most common. Small scope like flexible telescope is inserted to the bladder and ureter, and it is used to diagnose and treat a variety of problems in the urinary tract. It allows the urologist to investigate the ureter, find the stone, and remove it. Surgeon pass it a tiny wire basket into the lower ureter by the bladder, grab the stone and puts down to the ureter, make it stone free. So there are different sizes of ureteroscopes are available. So smallest one which is available is around 4.5 mm, and now which is commonly used is around 6.5 to 7 mm. That is commonly used. Yet yes, 4.5 is also available, and it is used in young females or where that we are suspecting ureteric diameter to be less than 4. Now coming on to the most common procedure, that is PCNL, that is percutaneous nephrolithotomy. As I told you, any stone which are more than 2 centimeter of size, whether they are symptomatic or non-symptomatic, PCNL is the procedure of choice. Used in patients with large or irregularly shaped kidney stones, people with infection stones that have not been broken by lithotripsy, so which are a failure of lithotripsy, those also can be treated. Best treatment for large stones in the kidney, stones that are bigger than 2 centimeters. to be done by PCNL. This procedure involves entering the kidney through a small incision in the back. From flank, we make a small incision, very small incision, maybe around 1.5 centimeter or so. Nephroscope, which is a miniature fiber optic camera, and other small instruments are threaded through the hole. Stone is removed through the tube, then it is got nephrolithotomy. If it is broken, then it is got nephrolithotripsy. Now, step by step, okay, this is how we prepare our PCNL patient. There are some closed surgical procedures which are now we don't do anymore. Now coming on to the open surgical procedure, yes, of course it is outdated, but yes, sometime when we are stuck up everywhere, somebody who's on blood thinner which you can't stop. There are certain indications like for kidney stones with the PUJ obstruction. Of course, there are open surgical methods which are to be done. For along with pyeloplasty, you just remove the stones also. Urethrolethotomy. Of course, I have not done it from the last 15 years, but it is there a book that I am telling you. Now, what are the emerging techniques? See, techniques are same. What are the trending is lithotripsy going, ESWL going down, flexible RAS going up, PCNL going up, open surgery and laparoscopic going down. If you ask me, the maximum size which I personally have removed by a PCNL is maybe around 9 centimeter or so. And in Guinness Book of World Record, that the only RG stone is holding, that stone's size was around 14 centimeter. That was done in a single stage PCNL. So any size of stone can be done with PCNL technique. So nowadays, if you ask me, technically there are no grounds to open up a patient. Yes, you might stage that procedure if you. Many patients come to me and they say, if I think open should be better. See, open is never better. See, for open, you are going to open the kidney also. You are going to dissect the kidney. Whensoever you see a patient, you do a contrast study of any before open surgery and after. Literature say there is always loss of around 10 to 20% of kidney tissue after open surgery. When you are going to open the pelvis, if you are not sutured pelvis well, there's good chances he will be having a secondary PUJ obstruction. There are a lot of complications. And another thing, my teacher also told me, okay, open is okay, but how many times? See, kidney disease is a recurrent disease. And of course, once if you are done your surgery, there are good chances. As I told you, in another 5, 10 years, 15 years, he's going to again form the stones. So how many times you are going to open? But yes, coming on to the PCNL, yes, PCNL, if you have done it, you can do it so many times. I don't say any patient should not require it, but yes, if you can do it multiple times, but if you have done already open, and the second time, it will be hell of the surgery. There will be a lot of additions. I don't think so many times people have tried attempted doing redo pyelolithotomies, ending up doing nephrectomies and all. Now, coming to the emerging technology, but it's at present mostly which laser is being used is that is a holmium laser. That can ranges from 30 watt to 100 watt. Now, what the new one is thulium fiber laser and brushed wave lithotripsy. Basically, these are the two techniques which break the stone. Now, thulium fiber is a several proposed advantages over holmium YAG laser. Its compactness and portability, it's for surgeon benefit actually. This wonderful for fibers, improved visualization and mobility. Actually, what is the difference for patient? It's a fragmentation is better than if you compare it with the holmium laser. And brushed wave lithotripsy, it's just now at presently, what the lithotripsy we are using is a pneumatic one. and now a new one has come, that is the burst wave lithotripsy. You can actually adjust your frequency so that your stone can, if at 170, stone can be in the big fragments. Then if you keep on increasing the frequency, it will be in the form of dust. You don't have to then pick it. They will just wash it with the water. Now, summary of surgical stone options, as I told you, ESWL, minimal invasive, no need for routine stent. Yes, but more than 1.5, you usually have to put the stent. Ureteroscopy, less invasive than PCL, but good stone rate or ureteral stone at the stone when they are less than 2 centimeter. For less than 2 centimeter, RAR is amazing technique. No doubt about it. It is the complete clearance, single shot technique. Somebody with the PCNL, see, no doubt about it. Whenever the stone is more than a centimeter, you don't have any other option. Open and laparoscopic and stone, of course, they are there, but they are rarely used nowadays. Again, same thing. There are the certain factors which decide which technology or which method you are going to use. There are some patient factors like prior stone history, preference, age of the patient, comorbidity, what are the BMI, what are the infection using, and then infection or sepsis. I told you if there is an infection or sepsis, first you have to deobstruct that kidney, putting a stent or something, then going to the either doing ureteroscopy, flexible ureteroscopy, or PCNL. Stone factors like size, location, multiplicity, density, and tonicity. And what the outcomes is expecting surgical morbidity, patient quality of life. If somebody is at home, middle age or old age, so multiple times she don't have any problem, so fine. So, but if somebody is working in MNC, you don't have any much of vacation, not much of leaves and all. Of course, you have to think of that also. Cost is very important. Hospital revisit, I told you, re-intervention. These are technology expertise, whether you have whole name or not, TFL, stroke lithotripsy, PCNL, ECIRS. Now, coming on the diet tips to prevent stones. Most importantly, 90% of work will be done by if you are going to drink enough fluid each day. You know, so many patients come to me and they ask, what is the optimum intake of fluid? See, there is no quantity as per you say optimum. It's changes according to age of the patient, which geographical area he's coming from, and what is the occupation of that patient. Most of the in 24 hours, most of the time where he's spending. You can make it like that. See, he should produce around 2 liters of urine per day. Accordingly, you can say how much drink he should be having. For example, a patient who is a laborer working 8 to 10 hours outside in the hot environment, even 5 to 6 liters is not enough. Okay. If somebody is always 24 by 7 is just sitting in that air conditioner area, so even a 2 to 2.5 liters is what I have. Okay. Now reduce the amount of salt in your diet. Very important. Eat plenty of fruits and vegetables. Eat food with low oxalate levels, like spinach and all. Eat less meat, specifically red meat. Eat the recommended amount of calcium. Now, key points are lithotripsy, rotoscopy, and PCN are acceptable alternative treatment for renal stones. Knowledge and safe practice of the available technique is the first step towards providing high quality care for the individual patient. Endoscopic, laser, and extracorporeal technology of the future may help in stone clearing and make surgery less painful. However, because these new technologies are expensive or focus on evidence production and that analysis, cost effectiveness, and patient quality of life will be necessary, there is little role for open or laparoscopic stone removal, except in unusual cases such as renal stones in setting of UPGO technique, PUJ obstruction. That way, I will thank you everybody, and I will welcome questions if anybody is having. Thank you.
Thank you, sir. Thank you. You can, sir, just stop sharing the screen.
Yeah.
So thank you so much, sir, for enlightening us with a very informative talk. It was indeed a feast of knowledge for all of us. Respected doctors, I hope you all had a very nice session. And as you all know, the session is brought to you by the Himalaya Wellness Company, the makers of the Cystone2, a safe, efficacious, and research-based medicines to manage urolithiasis. So now, before we move on to the session, I would like to invite my colleague, Dr. Abhishek Kumar, who has been working as a manager scientific services based at Ghaziabad. We will request Dr. Abhishek to please share the glimpses of Cystone2. Over to you, Dr. Abhishek.
Yes, sir. Thank you. A very good evening to all. Namaste. On the occasion of World Kidney Day, Himalaya Wellness Company presented this online talk by our eminent speaker, Dr. Sushil Kharbanda. Continuation with this discussion, I, Dr. Abhishek, would like to present about Himalaya Wellness Company is being a pioneer in the management of urolithiasis through plant-based medicine. The role of plant-based medicine in urolithiasis. First plant, that is Shil Pushpa, Didymocarpus pedicellata, or polyterpenes are there like didymocarpol, didymocarpinol, and this plant has got anti-lithiatic action through inhibition of calculogenesis, deposition, accumulation, supersaturation of calculogenic chemicals in urine. Mangista rubia coidifolia, rubric acid or mangostin are the active principle, and this plant is having anti-lithiatic action. So as per the various researches, hydroalcoholic extract of rubia cordifolia decreases calcium, oxalate and phosphate levels in urine, and that is how it is helpful in dissolving oxalate stones. Pashan bhed or saxifraga ligulata, the Latin word saxifrage itself means a strong stone breaker, or this plant has got lithotriptic action like inhibitory effect on calculogenesis, on the growth of calcium hydrogen phosphate dihydrate crystals. At the same time, it dissolves the mucin protein which binds the stone particles. Cyprus caryopsis and Ocimum basilicum, both these plants are having anti-inflammatory activity. Alkaloids are there, flavonoids are there, terpenoids are there, or glycosides are also there. So lupiol is one of the active principle in Cyprus caryopsis, which has got inhibitory action against interleukin 1 beta, which is a pro-inflammatory cytokine, and that is how this plant has anti-inflammatory activity. Acaranthus aspera and Tribulus tristis, both these plants are having diuretic action. Acaranthus aspera increases the volume of filtrate, and the Tribulus tristis, that is Goxura, increases the GFR. So all these plants we are having in our formulation, Cystone2 expels the kidney stones and prevents recurrence. So action of Cystone2 on urolithiasis, as discussed by our eminent speaker, Dr. Sushil Kharbanda sir, right from the nucleation up to the stone assembly, Cystone2 offers various actions, like it corrects the crystalloid-colloid imbalance, it renormalizes the pH of urine, it soothes the inflamed tissue and prevents implantation, it dissolves the mucin protein which binds the stone particles, or because of having diuretic activities, flushes the stone out of the kidney, or it exerts spasmolytic action to enable smooth expulsion of the stone. Coming to the clinical trial, evaluation of efficacy and safety of Cystone2 in the management of urolithiasis, and this particular study was conducted by Dr. G.R. Raman, a consultant urologist based at Balaji Medical College, Chennai, and this study was published in Journal of Urology and Research. So as per this study, a size of calculi ranging from 7 to 12 mm in 53.3% patient, we have seen a complete expulsion of the stone. Size of calculi ranging from 5 to 6.9 mm in 57.1% patient, complete expulsion of stone was there. And in rest of the patient, there was significant reduction in the size of the stone. Now, various clinical parameters that we have, and in fact, all these clinical parameters are were discussed by our speaker, like colicky pain, abdominal pain, dysuria, pain on micturition, hematuria, nausea or vomiting, fever, chills or loss of appetite. In all these clinical parameters, statistically, we have seen significant improvement. So conclusion of the study, Cystone2 is safe and effective in the management of urolithiasis with significant improvement in clinical symptoms and no adverse effect observed or reported. Or Cystone2 expels and reduces the bigger size stone ranging from 7 to 12 mm. Coming to the another study, it was a comparable study with Tramsoleucin, and it was published in Medical and Surgical Urology. The conclusion of this study, like Cystone2 tablets, showed comparable results with the improvement of clinical parameters in urolithiasis and at the same time expulsion of kidney stone as compared to the Tramsoleucin group. Indications are urolithiasis, stone up to 12 mm and cystinuria, and to manage post-lithotripsy complication. Doses, urolithiasis, urinary stone up to 12 mm and cystinuria, 2 tablets twice a daily till a stone passes out or till symptoms subside, and post-lithotripsy urolithiasis, 2 tablets twice a daily for 6 weeks is the dosage. So that is all from my side. Thank you. Thank you so much. Over to you, Dr. C.P. Shukla, sir.
Thank you, Dr. Abhishek. Thank you for sharing a very brief information about Cystone2 and the role of plant-based medicine. Sorry. Now, with much privilege, I request Dr. Kharbanda sir to address few of the queries.
Yeah, go ahead, sir.
Yeah. So one of the very, very important, sir, question which everyone has got, whether it's doctor, whether it's patient, and in fact, there are recommendations. We just would like to know your expert advice on that. How much water one has to take, or how much water is sufficient for patients? Because in spite of having all the best treatment options and the expertise in place, still the recurrence has been one of the challenge for everyone. Whether doctors or patient, it has been one of the very, very common challenges. So yes, in the preventive aspects, or even people who have undergone surgeries or invasive procedures, like how much water they need to take, or in fact, is there any kind of that they need to take soft water or hard water? How much water, the quantity of the water? So just we'd like to know your views on this, sir.
Very good question. I have basically tackled this talk also. See, amount of urine, amount of water intake is not fixed for everyone. You know, see, somebody, as I told you, some laborer, if he is working outside in summer season from 8 to 9 hours, if he is working in summer, dry summer like in Delhi, so maybe around 6 to 7 liter of urine of water is not enough for him. But somebody, if he is living in air-conditioned area 24/7, or some in winters, even 2.2, 2.5 liter of water is good enough for him. You know, so if how you calculate what amount of water you should be having is, see, you should be forming around 2 liter of urine in 24 hours. So you should target formation of 2 liters of urine in 24 hours. If he is working in plus minus environment or so, it's around 3 to 4 liter of liquid intake. Liquid intake means anything, means it can be plain water. Lot of studies has been done. It hardly matters if it is a hard water or a soft water. Amount of liquid matters, not the quality of water. Even it can be in a form of coconut water. It can be form of any chicken or something in a lemonade or something. The total liquid should be around 3 to 4 liter in a general way when you categorize. But most importantly, the geographical part where you are living in which occupation you are in 24/7, which at what temperature you are spending your day, because perspiration and all your sweating also it take part in what amount of fluid you should be intaking. So maintain around 2 liter of urine in 24 hours. That should be your goal.
Thank you, sir. I think yes, I think we need to customize depending upon the patients. Another one of the very important question which we have been getting, sir, can absence of any one can lead to the stone formation, because we have been especially people who have already undergone procedures. Many of the times they stop taking things which are rich into the calcium and oxalate. In a some amount it is required for the functioning, or in fact both of them get excreted out of our body once. So absence of any one can lead to the stone formation.
101%. See, if you stop taking calcium, okay. See what happens. Calcium oxalates are natural friends. Okay, they are going to make a bond. See, if somebody is not taking enough calcium, so what happens? Oxalate, when you taking any form of oxalate, see, there are all diets which has oxalates in them. There are some oxalate rich diet, but that doesn't mean other diets don't having any oxalate. So if you are consuming oxalate but you are not consuming calcium, what happened? Now in intestine, if you are consuming more calcium and oxalate, they are going to form a salt and it won't be absorbed into your kidney. But yes, if you are taking just oxalate but less calcium, then it will be absorbed and go through into your kidney, and there will be more chances of formation of stone. So you require in a balanced way, both calcium and oxalate. If you are having deficiency of one, either calcium or either oxalate, then there will be a more chances of formation of stone. Okay, specifically for calcium, I am saying.
Yeah, thank you so much, sir. Also, sir, one of the important question which has been there with respect to the salt intake, because there are in fact different types of salts which are present in our, and we have been using rock salt, white salt, and so on. So, is there any recommendation with respect to uses of other types of salts also?
No, not at all. So every salt, whatsoever salts containing salt, when you say sodium, I mean to say amount of sodium. See, if you increase sodium intake, then there are good chances, because sodium promotes stone formation. If you are taking any form of salt, if you may try to, so many companies say we make this type of salt, but any salt which containing sodium, it is going to increase the chances of stone formation. So type of salt doesn't matter, unless if it is containing sodium, it is going to be promoter of stone formation.
Yeah, thank you, sir. Thank you so much, sir. Another couple of important questions which we have been getting is about how uses of buttermilk is recommended, especially also the citric acid also. So how frequently one should use to keep himself fit and active and keep their kidneys healthy?
Of course, they will be helpful. See, buttermilk directly there is no impact on calculate formation. Buttermilk means if you are having 100 ml of buttermilk, it is forced. I'm just talking about the if you're talking about the stones. 100 ml of buttermilk is as good as 100 ml of water. So that means if you are taking 100 ml of buttermilk, that means you are consuming liquid. No other impact otherwise. And you asked me about another thing was buttermilk and
Citric acid, sir.
Citric acid. See, citric acid, as I told you, Indian population, most of the patients that we had found in urinary analysis for 48 hours when we had that, we found that they are having low citrates. Hypocituria is one of the most common cause of stone formation in Indian population. So having high citrate foods, having citrate means it should be in the moderate amount. No means you are in the morning, evening, night, every time you are having high citrate juices. Citrate juices if you are taking, it is going to positively help you in stone formation.
Sir, one of the question Dr. Altaf has asked about that, what is the impact of the ureteric calculi on the kidney health? So, Dr.
See, as I told you, when you are talking about uric stone, you have to classify whether what is the size of the stone, what is the site of the stone, and what is the shape of the stone. Now, what happened if any ureteric calculi, if ureteric calculi is now completely obstructing your ureter, that means at that time there is no urine which is coming down, and there is when our kidney is producing urine and it travels from pelvis to the ureter going down to the bladder. If there is some calculus in ureter, it's not allowing the urine to pass. If it is completely obstructing the kidney, of course, if you keep the stone like that, in another 4 to 6 weeks, you are going to lose your kidney if it is completely obstructing your kidney, obstructing your ureter. But if it is incomplete, of course, there will be hydronephrosis. If it is ureteric stone is there and it is allowing little bit of urine to go down, then of course, then at that time that that kidney can give you around maybe few months also. But if it is completely obstructing, not more than 6 weeks.
So thank you so much, sir. One of the last questions, sir. Many of the times, what happens in ultrasonography or even in CT scan, we can see that the stone size is bigger. Maybe it is 12 mm or maybe it is 14 mm, but it is not producing much of pain. So, what is the right time to go for the invasive procedures, or till what time one has to wait for?
I think this is the most important question that you had asked me. Okay. I tell you about my clinical practice. In a year, I had to remove kidneys, maybe around 15 to 20 kidneys I removed just because they were damaged due to stone. And I tell you, every patient whose kidney was damaged due to stone were asymptomatic. Okay. See, if you have a symptom due to some stone, how many days you are going to wait? See, if you are having pain, nausea, vomiting, fever, something, maybe you are going to try with medicine maybe for a couple of days, couple of weeks, maybe a couple of months. I don't think you are going to wait after that. But a stone which is not giving you any symptoms, okay, once there was pain, you had taken medicine, now you have forgot about it. These are the stones which are going to damage your kidneys. Because if they are symptomatic, of course, you are going to consult some doctor. Maybe after 4 or 5 days or so, but you are going to consult them. But as these stones become asymptomatic, people are not bothered. The stone has gone, but stone is still there. One thing. Second, you are asking about the size of the stone. As I told in my talk also, if the kidney stones which are more than 10 mm can mean more than 1 centimeter, that is the time you should start thinking of getting it removed. Why? See, even if they are asymptomatic, if they are less than 1 centimeter, you can observe, no doubt about it. But if they are more than 1 centimeter, you start thinking of getting rid of this, because the chances of spontaneous expulsion of a stone more than 1 centimeter is very, very less. One. Second thing, at the moment when it is, because with time it is going to increase in size. If the removing of any stone which is smaller one can be dealt with non-invasive techniques like flexible ureteroscopy and all. But once it is reached from more than 2 centimeter, or more than 2 centimeter, then only invasive method like PCNs are left. So whensoever a stone reaches around more than 10 mm, 1 centimeter, you should start thinking of getting rid of this with any surgical.
Thank you so much, sir. So I think the early diagnosis is the key of management. At last, they have to get analysis done and consult their urologist. Before concluding, sir, just request you to please share the take-home message and then your concluding remark.
Most important thing is my conclusion should be, if you are having any symptoms, of course, that's the time, of course, you are going to consult. If you know you have any stone, and you just are ignoring, I don't think that is the right thing to do. You should always consult a doctor. See, there are different kind of people in the market, in our industries also. Even if you are not satisfied with somebody's consultation, you can take second, third, or fourth opinion at least, but take the opinions, different opinions, multiple opinions of a qualified urologist. If everybody is saying like this, you should get it done. One. Second thing, just just eat healthy food, drink plenty of fluids, stop smoking, low salt intake, low animal food, and just plenty of water. That's where I would like to end my talk.
Thank you so much, sir. Thank you so much for delivering a knowledge enriching session and throwing much light and deep insight onto the topic of recurrent renal calculi and its impact on the kidney health. With that, we'll move towards the last but very important part of the today's session. As Zig Ziglar has rightly said, that gratitude is the healthiest of all human emotions. The more you express gratitude for what you have, the more likely you will have even more to express gratitude for. On behalf of Team Himalaya, I would like to express my sincere gratitude towards Dr. Sushil Kharbanda sir for his gracious presence as the speaker for the session and for sharing his valuable expert advice on various issues. Also, a special thanks to all the beloved doctors on board for your valuable presence and support and patronage. On behalf of team, let me also thank all Himalayans who joined hands together to organize this event. My deepest sense of gratitude and appreciations to all those who made this event a success. So once again, thank you one and all for the joining and making this event successful. Jai Hind, have a great day.